Hello, everyone. Thank you for inviting me to speak at this conference. Let me share my screen to start. Okay. Um, I'm going to talk about early diagnosis and intervention of Alzheimer's disease. I am Zahra Moussavi. I'm a professor at Electrical and Computer Engineering, also director of Biomedical Engineering at University of Manitoba. And these are the logos of my university as well as my lab. Alzheimer's disease is a thief. It comes and steals the most precious memories that people identify themselves with. It is a very clever thief indeed, because people who are affected, they don't know what they have lost. They only feel lost in time and space. Before I start on early diagnosis and treatment, let's see very briefly review what happens in the brain of a person who is impacted by the Alzheimer's. The picture on the right shows an advanced stage Alzheimer's after a death, of course, with autopsy, compared to a normal, healthy brain. Um, as you can see, there are a lot of differences, but I also should mention that these differences are quite obvious with this imaging at advanced stage, not at earlier stages. But as the Alzheimer's disease progress, the cortex shrivel up, damages in different areas, in particular the area that are involved in thinking, decision making, planning, and remembering. Shrinkage is especially severe in hippocampus. It's a gatekeeper of the brain, is responsible for forming long-term memories. And ventricles, as you see, enlarges in the brain with Alzheimer's. There are many fewer nerve cells and synapses, plaques, which are the abnormal clusters of beta amyloid proteins, fragments built up between the nerve cells. Also, there are tangles, which are as a result of excessive tau protein in the brain that keeps tangles, twisted strands of the tau protein. For us who are probably mostly engineers, we understand it better to think of synapses as the communication channels between the neurons. And in this picture, you can see healthy neurofibrils, healthy synapses. And due to the clusters of the neurofibrillary tangles of tau protein in Alzheimer's brain, these communication branches, these synapses, become destroyed and cannot pass the signal transition. Basically, the neurons cannot communicate well with each other. There are a number of diagnostic methods and monitoring. For sure, the clinical assessment involving a neurological examination of a neurologist or a neuropsychiatrist that they use usually a standard questionnaire. There are also technological diagnostic aid, most importantly MRI and PET imaging. But again, keep in mind that imaging is a great diagnostic aid. However, imaging does not have enough classification power to distinguish Alzheimer's at the onset of the disease, because as we age, our brain changes, and many of these changes are similar in the Alzheimer's brain as in a healthy older adults or with mild cognitive impairment. Not necessarily every change represents neurological disorder or neurodegenerative disorder. There are other types of diagnostic aid like TMS, paired pulse, latency in evoked potential, EEG analysis, egocentric spatial orientation, which is the technology that I use, I developed in my lab, as well as electro vestibulography, that again, it is something that we do in our team. In this 20 minutes presentation, I will not have time to go through any of these topics in depth. Basically, I can only review the titles with you. These two, as I said, are the ones that we do in our team, and I will talk a little bit more. As for the treatments, again, there is medication. There is no cure for Alzheimer's, but there are treatments. The medications are all into cholinesterase inhibitors family, and the most common one is Aricept or donepezil, with a very low success rate. In general, the success rate of medication is pretty low. It's about 2.5% response for a drastic change. For a mild response is about 30%. Non-pharmaceutical treatment, there are quite a number of research studies, and these are the list of them. One of these non-pharmaceutical treatment is RTMS, which is short for repetitive transcranial magnetic stimulation, or TACS, TDCS, short for transcranial alternating current stimulation, or TDCS, which is transcranial DC current stimulation. Daily cognitive exercises. The ones that are underlined are the ones that I do in my lab. There is also transcranial electromagnetic treatment, which is similar to locating, for example, a few radars, or even in a very lay language, like placing cell phones around the head and apply this radio frequency signal to the brain. And the paper, which was quite a good paper actually, presented that it does suppress tau protein. Of course, the sample size was very small. There is also hyperbaric oxygen therapy. There is light therapy as well, and music physical therapy. One thing to note is that the majority, almost all of these technological non-pharmaceutical treatment has been applied in small samples. None of them are conclusive to date to see which one is achieving better than the others. In my labs at the University of Manitoba, our dementia research involves diagnostic and monitoring as well as personalized treatment. What we do is we try, based on our diagnostic technique, we try to guess each patient is benefiting from which treatment the most. The treatments that we apply is RTMS, TACS, cognitive exercises, or cognitive exercises alone. I explain a little bit more about these, but again, not in depth. And of course, we monitor them with our diagnostic tool. So our diagnostic tool are being used both as diagnosis at the early stages of Alzheimer's, as well as monitoring tool for treatment efficacy. So far, the pilot studies that we have had for RTMS, we have had about 70 patients, which is quite relatively large. For TACS cognitive exercise, 29, and exercise alone, just 20. And we repeat our treatments every 4 months. One of our diagnostic tool is a virtual reality spatial orientation test. It has 2 stages. One is localizing a target from outside the building. The building looks exactly the same from everywhere. We assign a target randomly to one of the rooms, and we rotate the house and then ask the patient or participant where the target is. The next stage, if the participants pass this stage with 100% accuracy, we take them inside the house and tell them, go find that target room. MCI, mild cognitive impairment, or Alzheimer patients cannot do this stage 2 actually without training. With excessive training, MCI people can do it, but Alzheimer patients still cannot find the room inside the house. So their accuracy is actually zero when we get them inside the house. So far, I have tested this virtual reality house as well as its replica, which is a physical house. I use that for advanced stage Alzheimer's. I've tested it for on more than 300 older adults, which some of them over the time have developed Alzheimer's. All I can say at this stage very briefly is that this is quite a reliable test that can detect if someone is on the path to generate to develop a neurodegenerative dementia. It cannot distinguish between dementia types. It cannot say if it is vascular dementia or Alzheimer's, but quite with a high accuracy, it can predict if someone is developing Alzheimer's. We also apply electro vestibulography, or EVSG for short, which is a technology that we insert two electrodes um, inside the external ear, two very small cotton electrode, and we record the spontaneous activity of the vestibular system and analyze that signal, which looks like this one. So far, we have used it for diagnosis, separating mixed Alzheimer's from Alzheimer's, as pure Alzheimer's, as well as those people who have vascular symptomology. The accuracy has been greater than 89%. We also use it for monitoring the treatment efficacy, like RTMS treatment. And quite interestingly, which I'm excited about, is that we use it to predict the response of a patient to RTMS treatment at baseline before we start the treatment. And so far, its accuracy has been quite encouraging. It is about 76%, which is quite encouraging. This is our RTMS lab. RTMS is short for repetitive transcranial magnetic stimulation. It is relatively a simple machine. It has huge capacitors and a magnetic coil. Figure 8 coil is the most common coil that is used, and we hold it over the skull. The figure 8 winding is like that, so that the center of intensity is at the center of the coil. RTMS nerve stimulation is that it generates a magnetic field. That magnetic field induces an electrical field inside the brain, and that causes ion movements, means that the neurons are going to be excited. It can depolarize or hyperpolarize the neurons depending on the frequency. If we apply that low frequency, less than 5 hertz, it has it has the hyperpolarization effect, which means that it increases inhibition. But if we apply that high frequency, greater than 10 hertz, it depolarizes the neurons. Basically, it is excitatory. So RTMS treatment main parameters, number one parameter is the frequency, as I just talked about it. For treatment of Alzheimer's, everybody, including my team, we apply at high frequency, excitatory. We don't want to cause inhibition. Number of pulses is another important factor. We give at 1500 pulses. I have investigated 4000 pulses too, but it seems that it doesn't have much more benefit. So I'm settled with 1500 pulses per day. Treatment dose as how many days in a row. People have applied 2, 3, 4, 6, 12, or even more. I have applied at 2 weeks and 4 weeks, as well as 3 weeks as well. Target area, most commonly researchers have applied it to dorsolateral prefrontal cortex, mainly because DLPFC is the boss of the brain. It is the executive function of the executive brain, basically. And it has projection to many other parts of the brain, and stimulation to this area can lead to plasticity, or at least that is the mechanism that we hope to happen by RTMS treatment. Our current RTMS treatment protocol is, which is a multi-center international study. It is running, although because of the COVID pandemic, it has been on hold for quite a number of months, but we hope to resume it pretty soon. It is a randomized, double-blind, placebo-controlled study. We give 2 doses of treatment, either 2 weeks or 4 weeks, either sham or active treatment. We assess patients with ADAS-Cog, which is the most common standard questionnaire for Alzheimer's assessment. We also have a number of other assessments, subjective perception of the caregiver, as well as other questionnaire, and verbal fluency, NBAC, spatial orientation, and so on. We assess them at baseline, immediately post-intervention, and then every 2 months up to 6 months of the study to investigate the long-term effect as well. And all participants in the sham group receive the real active treatment after the 6 months of the study. Another treatment that we give is transcranial alternating current stimulation, TACS. Application area is DLPFC again. It can be applied at DC, which will be called TDCS, or at 10 Hz, 40 Hz, or random noise. I apply it at 40 Hz because this is the bandwidth that our brain generates when we focus on something and we pay attention and we are forming long-term. For example, right now that you are listening to this talk, you are generating gamma band 40 Hertz signals. Type of application could be cathodal or anodal, and the amount of current we apply at 1.5 milliamp peak to peak. It is harmless, painless technology and has no side effect actually. Nevertheless, we exclude people who have a seizure, history of seizure. There are 2 hypotheses for the mechanism that TACS could be effective. One is that it directly entrains brain oscillation, and the other hypothesis is that it can lead to synaptic changes via spike timing dependent plasticity mechanism. How about cognitive exercises? Well, there is a famous saying that use it or lose it for the muscles. So the question is whether this famous saying, does it apply to brain, to the neurons or not? Is it fiction or fact? There are some studies that claim, like this study, that claim that there is absolutely no benefit whatsoever of doing brain exercises. And therefore, I ran a study and asked that, is it true or false? So with my team, we developed a new series of brain exercises that we call it Mind Triggers app. I have developed it for iPads. I'm currently trying to develop it for Android and PC as well, but at the moment it is only available on iPads with the name Mind Triggers. It has 7 games, and these brain exercises are focused on visual memory, associative memory, left-right brain connectivity. This is one of the important games that I emphasize on whoever who uses it to practice this on a daily basis. And also, I personally like this game that I've designed. It is for spatial orientation. It does improve the egocentric spatial orientation. We train people to use geometry in order to navigate and target finding. The protocol to study that one, we have had 2 groups. One group only cognitive exercise, one group we paired it with simultaneously giving them TACS. Mind Triggers app was the one that we used. We have had independent standard assessment called WMS, and also independent spatial assessment. Basically, I measured the FAR effect of this intervention. So 19 people in only exercise group, 19 people in group that received exercise plus TACS, and 10 people received only cognitive exercise. The protocol has been 4 weeks in a row, 5 days a week, and every day for 2 sessions of half an hour. And moreover, every patient has had a dedicated tutor, an instructor, to give them a hand in how to do the exercises. Um, because I only enrolled dementia patients, people who have had mild cognitive impairment or they were at the earliest stages of Alzheimer's. I had a few vascular dementia as well as Lewy body dementia as well. Assessments were done at baseline, post-intervention, and follow-up a month after that. And we repeat this every 4 months. This is an ongoing clinical trial, and people come every 4 months for 1 month of treatment. The assessment, as I said, was MOCA for screening and WMS for primary outcome measure and the spatial orientation test. Here are some results for you showing the scores of WMS, which is totally independent assessment than what we trained our people. At baseline, post-intervention follow-up, there has been significant improvement in their scores from baseline to post and compare baseline to follow-up. To see it better, this slide shows only the changes from baseline to post and from baseline to follow-up. The interesting fact that you can see here is that people who received exercise plus TACS improved better at the follow-up, which means that even after a month that we stopped the treatment, these people who received TACS, they kept improving, which is quite an interesting fact because, and it makes me excited because it means that TACS really did help the brain plasticity. It did not only they were able to keep their improved state, but also they were able to enhance it furthermore. So in summary of this last study is that, first of all, more than 90% of participants improved. About less than 10% actually didn't improve, but these people did not decline either, which is important because Alzheimer patients are in a slippery road downhill, which means that they are declining. If we do anything that these people do not decline, then we are successful. And I had different people in this study, MCI, earliest stage, and some people, a few people were at moderate stage. Those at moderate stage did not improve, but the rest of people, 90% improved so significantly. And furthermore, as I said, application of TACS seemed to enhance and keep the improved state much better for a longer term. The paper has recently been published. It is on open access journal Frontiers. You can read it on the internet if you are interested. So the main conclusion in general is that non-pharmaceutical treatments seem to be effective than the medication, or at least as effective as medication. Some patients respond well to RTMS, while some people don't. It's important to notice that we are not claiming that these non-pharmaceutical treatments are for everyone. As I said, some people respond very well to RTMS, some people don't. But it seems that the response rate, based on my 70 patients data, it seems that the response rate is more than the medication, but we haven't finished the clinical trial, so I cannot talk statistically about that. Almost everyone in my studies significantly well responded to TACS with or without when combined with cognitive exercises. But the key important thing in that study that emphasizing on that is that I dedicated a tutor to every patient, and that is important. So the mode of delivery of these cognitive exercises is important. If you let patients to try on their own, they probably will not improve. They need a hand in order to improve. And pairing it with TACS seems it is much more effective. Therefore, I would say use it or lose it does apply to the brain, to the neuron. Everybody, healthy people, even young people, you have to use every neuron of your brain on a daily basis in order to keep it healthy and age with a healthy brain. And the key point in doing the exercises, another key point, is to keep them challenging and engaging. If you do repetitive exercises on a daily basis that you are master at it, it's not going to help. You have to challenge yourself with a new, challenging, engaging exercise. With that, I would finish my talk. And I would like to acknowledge the funding agencies, NSERC, Riverview Health Center, Western Brain Institute, and last but not the least, the generous donation of people, including Pachniak family. And also thanks to our wonderful patients who always volunteered in my studies. And I would like to dedicate my talk to my late mother who got Alzheimer's, and she was the source of inspiration for this research that I have done. And as I always said, a researcher is as good as his or her trainees, fellows. I have always been lucky to have a lot of brilliant students and volunteers. Thank you for your attention. I would be happy to answer any question that you may have. Unfortunately, this is not a live session, so you can send me your email questions by emails, and you can Google my name, find the email address easily on the internet.